Carolyn Buckee will be the next speaker. Carolyn is an associate professor of epidemiology at the Harvard Chan School and also assistant director for the Center for Communicable Disease Dynamics. Thank you, Carolyn.
Thank you. Thanks for having me. So I'm really glad there's a session on surveillance because we talk a lot about wartime, peacetime transition. And what that really means is that we have to move from reactionary, the normal actors that jump in when there's an outbreak, and move squarely towards health system strengthening and people on the ground, like Sachet was saying. And so I'm going to talk about some of the work that we're doing in my group. One of the things from an infectious disease standpoint, I'm not going to belabor this too much, but the growth in population density in the last 100 years is really setting us up for some major risks in this respect, particularly in South and Southeast Asia. But also, the rapid urbanization of the world is having a big impact on our vulnerability and risk. This graph just shows the fraction of people living in cities over time, comparing 1950, 2007, and projections for 2030. I think we passed 2014 was the year that there were more urban than rural people. So we have this growth of megacities, highly connected, and then these zoonotic threats in rural areas as well. But we're living in a very rapidly changing world. And of course, we all recognize these flight patterns nowadays, and the global risk from local outbreaks is really important. But it also, I think, highlights the fact that any pandemic starts locally. So we really have to get down to the national control program level when we're thinking about pandemic preparedness as well. So my group, we think a lot about national control of outbreaks, and we work with national control programs, mostly in malaria and dengue. And essentially, on that level, what a national control program has to do is allocate resources effectively and figure out who has a particular infection where they are. So on the top left, you're looking at a malaria risk map of Cambodia, and you can see that there are the dark red is where there are more cases reported from clinics. And so you have this heterogeneous distribution of disease prevalence. And as a control program, you have to try and allocate resources effectively to the people to the population at risk. And then the feedback loop is that there are reports from clinics and hospitals, and you're trying to do this in an iterative loop. And that forms the basis of many of these decisions, and even during an outbreak. And so I'm going to talk about some of the things that we think could help do a better job on the surveillance side, so taking reports from clinics and hospitals and helping national control programs make better decisions about where to allocate resources. A huge aspect of this, and Sachet talked about this a bit, is the impact of migration. And it's not just, on the right here we have international migration, which of course we all worry about from a pandemic preparedness standpoint. But for a national control program, you're also worried about internal migration and migration across borders, because what that does is it spreads disease within your own country, places you thought you'd reduce transmission. Travel can reintroduce transmission there. In my work, we do malaria, and critically, what you do to reduce transmission levels, basically reduce the mosquito populations, is not necessarily the same as what you would do in a place where many people are coming in with imported infections. So these differences really matter in a very concrete way. So we've been working with mobile operators in particular over the last 5 years, because mobile phones are now everywhere, as you are all aware, and the mobile phone operators routinely store location data. And what that means is that they have real-time information about where everyone is and where everyone's going. And in almost any kind of disaster, an outbreak included, and in any infectious disease spread model, that's fundamentally what you need to know. There are 10 cases from this clinic. So what? How many people were at risk there? Where are they going? Where is the disease going to spread next? And so having access to private data, given the privacy concerns, and we're working through some of those methodologies, being able to tap into these new data streams, which really we had nothing before them, being able to tap into these scalable data streams to help us with our risk mapping is going to really make a difference when we think about surveillance and response to outbreaks. And the bottom line is we use mathematical models and we incorporate and integrate different types of data streams to help control programs move from, for example, a dengue risk map that looks like that on the left. This is Pakistan, and that shows the vector suitability for dengue outbreaks at a particular point in time. This was 2013. You can see everywhere is red. Once you incorporate mobility information and epidemiological relevant data, you can move to a map like the one on the right, which says epidemic risk is really high in Lahore and Islamabad. That's where you need to do surveillance. So just from a resource allocation perspective, and low resource settings are where we really care about this, this is hugely more efficient, and we can do this on a regular basis. So this is a forecasting exercise that is made incredibly more effective with different types of data streams. And it's not just mobile operated data, although that is an extremely useful source of enormous amounts of information. There's also Google data and Facebook data. There are all these new data streams that we can incorporate into our models. And it's not just predicting outbreaks, which is very important and why we're here, but even allocating resources for aid in response to flooding. Where did everybody go? Where do we need to get tents or food? And so these types of data are really cut across some of our sectors, and they're really critical. So I'll just finish by talking about a particular project. This is a movie, I don't know if you can see. This is data from nearly 70 million subscribers in Bangladesh. And what you're seeing is the shift of the population during an Eid holiday. So during Eid, everybody leaves Dhaka, which is in the middle of the country there with the red, it's dark blue in this picture. Everybody leaves Dhaka and they go to the rural areas, and then at the end of the holiday they come back in. Okay, so we can measure this in real time, and we can start figuring out what that means for our infectious diseases. We know that holiday travel everywhere drives a lot of outbreaks, and it's an important factor. But the important thing here is that we now have a scalable, sustainable source of information on this that can be, in fairly simple ways, aggregated and shared with control programs. So for me, the most important next step, we know this data is important, we know that we can do these modeling exercises in a relatively straightforward way analytically. Really, the difficult piece is navigating the political and regulatory environment, getting capacity building, not just on the operator side, but also in the control program side, making sure that the Ministry of Health sees the value in these types of forecasts and information systems, and then making sure that people are trained to make sense of all the data. And this has been a repeated theme, I think. It's not just having lots of data. It's really what you do with it, how you combine it with the epi data. And you can't get away from the fact that any forecasting model, any infectious disease model, is only really going to be useful if you have good clinical data. So you can't use big data to replace these basic health systems information. So in Bangladesh, we work with their malaria control program. And just to show you that, so a regular national malaria control program would have this map on the left, which basically says how many cases are reported in a certain amount of time. And as you can see, as in many areas of the Greater Mekong subregion, actually, the forested region on the border, this is the Chittagong region in the southeast, where the Rohingya camps are, actually. The forested region, which borders Myanmar, is where most of the malaria is coming from. It's forested. There are lots of movements for agricultural labor and other reasons. And that's what the malaria control program normally has to deal with. Once we've integrated some of these data streams, and it's not just mobile phone data, it's also genomics data. So pathogen genomics, we heard earlier about the Virome projects. Pathogen genomics can tell you a lot about gene flow, how infections are moving around. And we combine these types of information, and we end up with a risk map like the one on the right, which says, yes, the forested regions are your high incidence areas, but these are all the areas where we're going to get a huge amount of imported infections. They are going to sustain local transmission where there are malaria vectors, and you need to make sure you can do imported malaria control in those areas. So really, it's about trying to add value for the end users, for the actual control program. And critically here, we've done a lot of years of mapping people, teams of people going out, mapping the villages. Where is everybody? Combining it with this kind of data. If you have those people on the ground for an endemic problem like malaria, those are going to be your first responders when there's an outbreak, and that's absolutely key. I think during the Nigerian Ebola experience, the contact tracers from the polio program were really instrumental in shutting that down and shutting the Ebola cases down. And so again, it comes back to what Masoka Falo was saying, human capacity is absolutely critical here. And I think we have some of the analyses, we have amazing technology. The big work here is moving it into the field and to the first responders. And I'll just finish by saying that in an outbreak setting, during Ebola, there was a lot of interest in trying to get hold of mobile phone data to understand where people were going. It was challenging. And in the end, we did get some data, far too late. It could have happened in real time. But what we were able to show was that using a really, really analytically simple anomaly detection algorithm, you can measure the impact of travel restrictions in real time. It's very easy. This is not rocket science at all, right? It's just knowing how to aggregate and analyze the data, that's all. So here you just have movement from a particular chiefdom over time, and the red bar shows you where a bunch of anomalies were detected, which happened during the travel restriction. And interestingly, in that window, what we could show was that the extent to which people stopped traveling was highly correlated with how much Ebola they had experienced, which makes sense, right? Because if you'd experienced Ebola and you were told to not travel, you probably paid more attention than if you hadn't really had much of an impact on your community. But again, it just shows the importance of figuring out what data you need, how to use it, and then translating that in a timely fashion. So we hope that we'll be able to develop the regulatory and political will to move this beyond academic exercise into translation, and that, I think, is actually a huge challenge. So just to end, when we think about this framework of resource allocation and then understanding what's going on with your epi for surveillance, we have so many new tools and technologies. Mobile phones are everywhere, and they are a great resource, not only for observing your population, but also for engaging with them. I didn't talk about that much, but that's a huge part as well. Participatory surveillance can really help. And so I think the translational piece is really hard. The incentives are often not aligned. Here at Harvard, we're incentivized to write papers. And that's great, but how do we move beyond that to do capacity building and get these analytical pipelines into the populations that need them? That's going to be really critical when it comes to pandemic preparedness. Thank you.